My name is Amit Safir. I am a biomedical engineer from Mexico. I moved to Israel 6 years ago. I have about 6 to 7 years of experience working with medical devices. I'm here to speak with you about mobile health. I know all of you guys are developers. You know exactly how to use phones in the inside and in the outside, and how to make the phones do whatever you guys want for whatever goal you want to reach. We at MobileOCT leverage the technology that a mobile phone can give us. In our case, optical technology, but I'll show some example of other things that people are doing to create a better world, specifically to bring cancer screening optical tools to everyone. So let me begin by explaining what's the size of this opportunity that we currently have. There is a mHealth market that's supposed to reach $23 billion in 2017. Just so you understand the difference. Diagnostic services in the US is $3.4 billion. The opportunity here is massive. Usually when you speak to either investors or developers or people that are interested on bringing technology to emerging markets, let's say I'll speak emerging markets and I'll just say Africa. The initial response is they take a step back and they say there's no money there. But there's actually a lot of money. These are emerging markets. These are people. These are needs. And you can go ahead and do the research by yourself to see that these numbers are true. Just speaking about mobile phone, statistics show that mobile phone user base will increase in emerging markets, will double, if not triple, from 2012 to 2016. There's trillion sources for these type of statistics. Not only that, but I had the opportunity to travel in Africa in 2011 in East Africa. You have really good mobile phone signal anywhere you are. These emerging markets, these developing countries skipped phone lines. So the only communication resource they currently have is mobile communication. That's why their networks are sometimes a lot better than networks in developing countries. I used to live in San Francisco, where the network was shit compared to the network that I found climbing mountains in Africa or in the Serengeti in Africa. Pretty surprising, actually. We've all heard about telemedicine, the idea that a patient can be located in Zimbabwe and the patient gets an X-ray, and the X-ray is analyzed by someone in Cleveland Clinic, by a top-tier cardiologist, whatever. Diagnostic comes and the patient can go home. Well, that's not the real case of what's happening in the developing world. This is possible, totally possible. You send the image on satellite, the next day the radiologist come to the office and the radiologist looks at the image and then sends back. Let me give you a better idea of what is happening there. Medical clinics in Africa, in South America, in some places in South America, I should say, some places of Southeast Asia are crowded places. There's a massive amount of influx of patients, and these patients don't come to the clinics for for like a, let's say if we're talking about cervical cancer, which I will speak about later, cervical cancer in developing world, in the developed world, you get a pap smear, and then you get a biopsy, you go colposcope, and the patient can go back and forth from their apartment in Herzliya or Tel Aviv into Asuta here in the building. That's not the case in Africa. Patients have to walk miles to get to clinics, and they're only going to be there once. You know, if they're lucky, they'll come back in 10 years, but nothing more than that. So it's important that the treatment happens on the spot. This is why screen and treat methods were developed, where you try to get a diagnostic as quick as possible, and then you treat. So where am I going for? What's the point I want to make? There is a need for in-the-spot diagnosis. Most of these places do not have either the capacity to get medical devices. If they do, it's only in one clinic, not in all of the clinics. And there is a need to make the diagnostic on the spot and the treatment on the spot. That's why mobile phones are such a brilliant idea to use in healthcare. I'll speak a little bit about the advantages of using mobile phones in healthcare. Learning curve, for example. These workers in Africa, in Southeast Asia, anywhere in the world, they carry smartphones. And if they don't carry smartphones now, I would put money in the table now that they will carry smartphones in 5 years from now. They know how to use these platforms. If I ask you which device here sounds more familiar to you, or what's easier for you to use, all of you guys will obviously say you'll take the phone. You know, everyone knows how to use an iPhone. Everyone takes pictures in Instagram. You all know how to take an image, how to look at images, how to slide. This is very, very easy way to teach someone how to use it. And it's being used a lot. Number two is the high quality of the sensors that you can find on the phones. You have excellent visuals and visual gathering technology. You have really good cameras. Just as a small comparison, we are right now using Android phones. We're using Nexus 4. Nexus 4 has the capacity of working with something between 4 to 8 megapixels, if not more. Maybe we have an old version. 4 megapixels is more than enough for looking at medical images. You don't need more than that. So imagine using Windows phones now that have about 20 megapixels. You can get incredibly high definition of those images. You have microphones, very high sensitivity of microphones that you can use. You have extremely exact GPS sensors. You can know the exact location of the patient anywhere he is. And you have motion sensors. A lot of this is also being used with the new emerging wearable technology that's coming up. I'm sure you guys know more than me about it. I'll speak a little bit more about this type of applications. There is, I set up here just a few examples. Path is a global company that invests a lot of money on bringing healthcare services into the emerging world, into developing countries. They have a program where using SMS, simple SMS technology, doctors can fill out medical records of their patients and get somewhere in the cloud the whole patient history. Very simple use of mobile phones. They don't even use smartphones. They use old Nokia phones to keep track of their patients. Not only that, but patients also use their phones to record and to send to the doctors their status. So they send how they've been feeling, how's the new pill dosage that they got, etc., etc. I also got to see a lot of amputation, so graphical record of let's say amputation of lesions. So patients could send through MMS these images to doctors. GPIGO is a company located in Johns Hopkins University in Baltimore. They are also fighting cancer using mobile phones. What they're doing is they have this kit that they send to these clinics, and the kit they basically the kit involves a mobile phone. They do blood tests on the spot, and the blood test results are sent through mobile phones to clinics in Johns Hopkins. The Kilimanjaro project is a project that's doing something similar to what we're doing, and don't worry, I'll explain what we're doing. Kilimanjaro project is cervical imaging using also mobile phones. What they do is they take simple images with, I think they're using iPhones. They take an image of the cervix. If there's a lesion, the images are sent somewhere abroad, and they do somewhere probably in the US or Canada. I think it's Canada because they got a bunch of money from grand challenges. Cellscope is a company located in the US. They check ears of little kids. So if your kid has an ear problem, then you can look at the ear, inside the ear. And Taito, which I don't know if you guys are familiar, they're an Israeli company, brilliant company. What they do is super cool. Is that blue thing that you see? That the mother is checking the kid. It's basically a whole diagnostic platform for mothers to check their kids. So what they do, very smartly, is they use all of the capabilities on the mobile phone. They're not using a mobile phone right now, but the original idea was using a mobile phone. So what they do is they do visuals. You can check heart rate using a small sensor that's connected to the microphone jack, to the headphones jack. And not only that, but you have online communication with your doctor. So your doctor using Skype or Google Hangouts, we're here, I must say, Google Hangouts. You can see, the doctors can see the same images that you're seeing, and the doctors can direct, move the phone a little bit to the left or to the right. Very cool what they're doing. So what we're doing, MobileOCT has a proprietary lens that bends the light in a certain way that we can do polarization imaging technology. I'll explain very briefly. I'm not going to get into the scientific part that much, but basically polarization difference imaging, if the epithelium, which is the tissue that covers all of your organs, is formed by 3 layers, when the light goes into your skin, let's say the skin or anywhere else in the epithelium, what you see is 10% of the light that comes back immediately reflected from the superficial layer, and then about 80% of the light that's reflected from the basal or the deeper layer. That's why your skin looks red most of the time, at least. And then the middle layer is about 10%. Now, cancer grows in that middle layer of the epithelium. When you try to see cancer with your bare eyes, what you see is a small lesion. Doesn't look exactly, it can be any type of lesion. It can be a cut. It's not very specific. So what PDI does is it takes the deeper part, the deeper image, deletes it erase it from the image, and all what you see is the superficial and middle layer. Using this and combining this with what's happening in the developing world, this allows us to use this allows the workers in the clinic to do real-time triage. which means they see the image and they can much easier decide if this patient requires treatment or not. So now I believe that this will explain you guys what I mean. This is how cancer screening is done today in the developing world. There's about, I'll speak about the numbers later, but I'll explain about how the procedure is without being too gruesome and too graphic. What you see there is a medical professional. It's not always a OBGYN. Sometimes it's a nurse or some high school student that was taught how to do this. What they do is they look into the cervix. They use a speculum and they look into the cervix with a light like the one that they have, like the one that woman has. If they see some kind of a lesion, they put a little bit of acetic acid or vinegar, and the lesion goes through a acetowhitening process, which means that the lesion will start to look a little bit white. And then they decide, according to that whiteness, if this is a risk for a cancer or there's no risk for cancer. Obviously, with this technology, you can expect that the positive predictive value is very low. There's about 5 out of 6 women that are treated that do not have to get treated, that are suffering the pain, suffering the economical burden, at least the health organizations are suffering the economical burden, and they're suffering the risk of later infections because of this. And this is the point that we're trying to solve. We're gonna bring the positive predictive value from 17% now up to 70%. This will, first of all, allow for much more screenings, allow for much more women that really need the treatment to get treatment, and will also help healthcare companies to save some money on this. So this is the result of the image that we can give, the image that you see in red. The image that you see in green is what they currently see. This image is done in skin, not done in cervix. Just not to, I don't know what can be the reaction of you guys when you look at the cervix, but this is the image that you see in skin, and this is the image using PDI. As you can see, it's very clear to differentiate between the images. I must say that our technology is a very simple adaptation of optical elements into the phone. What we're using here is the optical power that a cell phone camera has, the high definition of the image, and just a little bit of optical elements. If these elements were not simple, we wouldn't even have a game on going into developing countries, because this is so cheap and healthcare companies can actually afford this, afford for these clips and add them to their phone. This is why we're actually aiming for the developing world. So, how are we planning to make money? If you guys were asking yourself, we're gonna take 2 business models. The first money is pay as you go PDI images. We sell tests or we sell checkups as credit. The companies can buy 100,000, as many checkups that they want, and we charge them every time they use it, just like mobile phones companies charge for minutes. They can also do pay as you go. The second model is using premium services. Using the connectivity of mobile phones, this allows us to take images and send them to the cloud and process them in the cloud. What we're planning to do, or what we're already doing, just not with mobile phones, is sending the data of the images to the cloud and doing multiple spectroscopy. What multiple spectroscopy does is it sends back results of the contents in that tissue. So we can say there's this percentage of oxygen, this percentage of water, this percentage of blood in that tissue. Together with that, we offer telemedicine, of course. In cases that it's not really clear or it's complicated cases, they can send these images up to medical centers that, by the way, we already spoke with a lot of clinical partners. They're all fascinating by the idea of something so simple having such a big impact. So, what are we doing here with mobile phones? We're doing innovation, which is basically the speed and the ease and reliability. What mobile phones are actually helping us is to leapfrog all the technology infrastructure. Just so you know, in the developed world today, any woman that goes and see the doctor, the OBGYN, doctor, if he's gonna look at her cervix, he's gonna do it with a colposcope. Colposcope costs about $20,000. Our technology probably will give it for free to these clinics. If somebody wants to buy it, will not cost more than $100. At least that's what's costing us right now. 3D printed models, it's not costing us more than that. Once we mass manufacture, the price will go even lower. Mobile diagnostics is a market that's growing. You guys should be aware of that. There is a lot of interest in that. Not only that, but the impact that you can actually do developing something like that is much bigger than the other apps that I've seen around. These are our team. Our CEO is Ariel Berry. CTO is David Levitz. He's a PhD, has about 13 years of experience working with tissue optics. And we have a bunch of advisors all over the world that are helping us. So I want you guys to take two things out of this. First of all is the real size of emerging markets. Going to global markets is not always less money. It's not always looking for less money. Sometimes, or even most of the time, you're looking at higher profits. Second thing is that our technology is right now aimed for cervical cancer. The change from the model of cervical cancer to a skin cancer detection model to a mouth detection model is just a matter of changing the case. It's very simple, just a matter of design. Using the same capabilities that mobile phones can give you. And one last thing. Just so you understand the size of mobile health, Google recently launched Helpouts. Helpouts is a Google platform that works just like Google Hangouts, but this is for professionals to give services through a video conference. They got HIPAA compliance. HIPAA compliance is a privacy setting compliance that you require if you're going to use medical data. Google is looking at this the same way as we're looking at this, the same way as many other companies are looking at this. There is a lot of potential. I want to invite you guys to, take your developing efforts and really move it towards something that can change the world, something that can have a real impact. If it's not in the people that don't have the money, then at least do it for the people that have the money. But you guys know how to do these things much better than me, at least, much better than all of us that work in MobileOCT, actually. None of us is a programmer. We outsource all our programming work. But the potential of taking phones and using them for diagnostic and for treatment is huge. Thank you very much, and I'm happy to answer any question that you have.